So, as I'm sure you've all gathered, we're going to talk about SAINT today. I have no disclosures. There are three big learning objectives. I think first and foremost, and this was really important to me too when I started out looking into this, there are a lot of acronyms surrounding SAINT and TMS and just everything. I think demystifying that whole space is very useful. It also so happens that going through some of the acronyms and talking through them will help provide the background education, and the context towards then going through the evidence, right? Like, I think that's the big question. Now that SAINT's a thing, now that we have this new technique that's been around for coming up on 7, almost 8 years, what does it look like in mood disorders? And we're going to discuss both depression and bipolar disorder. And then lastly, there are some future considerations that I have, like when I think about the work we did, when I think about everything I hear related to SAINT, I think there are some things that naturally come to mind, and I want to touch base on those too. So what is SAINT? SAINT is an acronym that stands for Stanford Accelerated Intelligent Neuromodulation Therapy, and I actually think going through the acronym is a very good way to understand what the treatment is. The S is for Stanford. Two gentlemen, Nolan Williams and Brandon Bensley, worked at Stanford in the Neurostim lab at the time. They also so happened to both do residency and fellowship at University of South Carolina together. And they tell me that one of the main driving impetuses of looking into SAINT, trying to create SAINT, was addressing a need that we're all very familiar with. And that's how long many treatments take, right? This translates to both suffering and negative experiences for patients, but also longer inpatient stays, ED stays, et cetera. There's a lot of downstream rippling effects. So there's always been this need, and for them that was very real. Brandon has since gone on to form a company called Magnus Medical, which I mention because Magnus has the rights to develop and market SAINT. So although Stanford has the IP, when we think about SAINT going forward into clinical practice, when you send patients out, when we look at clinics like Acacia, Magnus is the name you're going to see. So I just want you to have heard it. A is for accelerated. To understand what it means to be accelerated, we should step back and just discuss TMS as a whole. This is when we're going to go through some acronyms. TMS stands for transcranial magnetic stimulation, and broadly just refers to any time where we use a coil, in which case I have 4 pictures of what's called a figure 8 coil, if you can imagine kind of this 8 shape, most easily seen in the bottom left. And we pass a current through that coil, which creates a magnetic field, and when we pulse that field, it creates a downstream electrical current on a target, and we hope that that pulsing of the field, creating the electrical field, helps produce the symptom changes that we want. So the key word is pulsing there, because that's going to be the first major parameter we talk about. So we're discussing 2 things on this slide. These are the 2 first acronyms. One is RTMS and one is ITBS. RTMS, repetitive transcranial magnetic stimulation, is really what we typically mean when we use the acronym TMS. When we say patient got TMS, or we refer to a patient to get TMS, we are really sending them often to get RTMS. And RTMS is the repetitive, equally spaced pulsing of the coil. So how do we measure how fast the coil actually pulses? We use hertz, hertz referring to 1 per second. So in the very top, you see this 10-second window. There are 10 vertical lines. This is 10 pulses in 10 seconds, 1 hertz. Just south of it, you see a 1-second window. 10 pulses in 1 second is 10 hertz, etc. So many different hertzes, many different pulse frequencies have been tried, and we've found over time, TMS has been around for a couple decades now, that certain ones are inhibitory, certain ones are excitatory, and 10 hertz is what is typically used, to promote the changes we want. Then in the 2000s, ITBS, intermittent theta burst stimulation, came around for a couple of reasons, but one of the main things, and we'll discuss this in a future slide, is that typically when patients get RTMS, they're there for 30 to 60 minutes. We roughly tell them an hour, and that is quite a bit of time. That's certainly longer than ECT takes in terms of the treatment itself, not excluding the anesthesia. But that length we can shorten, and that's what we did with ITBS. So what do we see in ITBS? You are still pulsing. Specifically, you have a 2-second window where you give 50 pulses, a lot of pulses in a short window, and then you have an 8-second refractory period. And this notion of pulse, longer refractory period, pulse, longer refractory period, is designed to try to mimic endogenous brain firing. Like theta firing in the brain is 4 to 7 hertz. We do it at 5 hertz, just as standard practice. But the idea is, maybe we can mimic this neuronal firing, whether it be in the hippocampus, the frontal cortex, etc., to produce better changes. And in fact, we can. So in 2018, there was a very large multi-center trial which compared rTMS at 10 hertz head-to-head with ITBS, as shown here, and they were found to be non-inferior. And ITBS is now just a very well-documented, well-used technique, and it takes about 3 to 10 minutes. So that is compared to the 30 to 60 above. So this is the last big acronym to know. Accelerated ATBS is really where the conversation is currently. And accelerated TBS basically just refers to any protocol where you have more than one ITBS session a day. So this can look like a lot of different things, right? You could have 2 a day, you can have 5 a day, one is at night, you can have 2 a day an hour apart. There are so many ways that you can create permutations. So a lot of the conversation now has been what combination of these permutations is leading to the clinical results we would want, and there are many different ones. So when we discuss SAINT, we are very specifically discussing a specific ATBS protocol. Someone has done, specifically Brandon, Nolan, et cetera, their group has done the background, the neuroscience work to identify how do we optimize these conditions to try to produce results. So before we go into SAINT proper, I just want to highlight one thing on the top 2 rows, rTMS and ITBS. They're 6 weeks in duration. So patients, classically, when they get either, are coming every day, Monday through Friday, for 6 weeks straight. And that can be a financial commitment, a time commitment. You have to get off work, or you're coming before work. It's not easy to actually do that. So SAINT is 5 days straight, but you're there for 10 sessions a day. So these are long days, and I can discuss that if people have questions about what the provider experience is like. Each session is 10 minutes, like Joshin said, and then you're followed by a 50-minute break. This was very specifically designed out of literature looking into kind of this refractory period, this intersession interval, as they call it, and they optimized it around an hour because they found out long-term plasticity and change was best induced through that time. And then you'll see this red arrow from 18,000 at the end of ITBS down to 18,000 in SAINT. So what this means is in one ITBS course, when you do ITBS for 6 weeks, you give 18,000 total pulses. And in SAINT, you do that same thing every day for 5 days straight. So that in part is the accelerated nature too. You're doing it for 5 days, you're there for much longer each day, and you're giving much, much, much more over the course. So we'll discuss a couple things out of this, but the biggest thing I thought of when I first heard about this is this safe? Right, this is so much more. So safety is something we'll discuss. Efficacy is certainly something we'll discuss. But I just wanted to give everyone a sense of how we got here in terms of the acronyms. So I is for intelligent. And intelligent, in my opinion, can also stand for individualized. I can also stand for individualized. We should briefly touch upon how we actually target SAINT, how we target rTMS or ITBS or any of these techniques. We have a structure in the brain that's implicated in many things: executive functioning, emotional regulation, et cetera, decision-making. But consistently, through decades of work, it's shown to be hypoactive in depressive illnesses, whether major depression, bipolar depression, et cetera. So naturally, it's become the target. How do we do that, and how have we done that typically? Since TMS came about, we've used anatomic landmarks. There are a couple different techniques. The big one is the Beam F3 method, where you measure head circumference and tragus to tragus and nasion to inion. And using those 3 measurements, you can roughly do some calculations and identify a placement on the scalp that we place the coil to tangentially. A big innovation of SAINT, but also had been done roughly around this time, is using fMRI to try to generate this target instead, specifically resting state. Patients go through 4 series. It's actually pretty rigorous. They can't move at all. I had many patients have to redo their 4 series. So the image quality needed to generate this target is pretty high. But once generated, it seems to be very good and sustains, as we'll discuss on the later side too. So why are we targeting this section? This is the other part of what the theory of SAINT is. So on the very left, you see 2 structures. Above is the dorsolateral prefrontal cortex, which we've discussed, and below is the subgenual anterior cingulate cortex, SGACC. So these in a healthy, normal brain have a classic relationship in which the upper structure inhibits the lower structure. And like I mentioned, in depressive illnesses, we see decreased activity in the dorsolateral prefrontal cortex, which is why it's now blue. And decreased inhibition leads to hyperactivity of the latter structure, the subgenual anterior cingulate cortex. And when this is hyperactive, we see a lot of the accompanying symptoms, right? We see sadness and negative rumination and cognitive change, etc. And the idea is to use TMS, whether it be RTMS, ITBS, SAINT, to target this area to restore this connection, to restore this inhibition pattern. Specifically, you'll see bolded up top, we're looking for the most anti-correlated area. And that's the idea behind the resting state fMRIs. The idea being that, we have many tracks going from the top to the bottom structure, but certain areas that we can discover, that they can discover through image processing, are responsible for the most inhibition, this most inverse relationship. So that's the idea behind the targeting. And then N is for neuromodulation therapy. So neuromodulation therapy we've discussed at length now, right? TMS is a neuromodulation therapy, but we should step back to also understand that neuromodulation therapy just refers to any time we modulate the nervous system to try to affect certain changes. So although I list ECT and TMS and SAINT up here, DBS, vagal nerve stimulation, etc., these are all also neuromodulation therapies. But I put these bullet points for two reasons. One is just to remind everyone of the relative efficacy of ECT versus TMS as stands. ECT has been gold standard, almost coming up on a century now, very, very good. And naturally, any discussion of any new neuromodulation therapy has to be done in the context of ECT. That is the question behind the scenes always, right? Like, how does this compare? What are we actually going to give patients the option to? What is not here is the other side of ECT, which we're familiar with, which is the side effects, the cognitive side effects, potentially headache, aches, etc. The reasons that patients might be reluctant to get it, besides stigma alone. Patients may be reluctant to re-get it, etc. So that's part of the conversation too. Is SAINT effective, and how does SAINT work side effect-wise? So we're first going to look at SAINT for treatment-resistant depression, and this is really major depression. The reason I put treatment-resistant depression is the 3 studies we're going to go through all use this treatment-resistant depression moniker. All their patients have failed at least 2 antidepressant full trials. Most of them, when you actually look through the papers, have failed 4 or 5, etc. So the first paper is in 2018 by Nolan and his group. In this paper, they don't even mention the acronym SAINT actually yet. This is actually more a proof of concept paper in my mind. They look at ECT non-responders, and then they run them through SAINT, although they're not calling it SAINT at the time. And the figure, the big nugget of this paper, in my opinion, is this figure where you have an arrow pointing to the subgenual anterior cingulate cortex, and you have one pointing after SAINT treatment. And it's a little bit hard to see the legend, but blue is 0, and green is minus 0.8, or almost into -1, really representing the change in the negative relationship between the structure that occurs with SAINT treatment. So you see this shift from blue to green. And this, I think, is the theory manifest, right? Like, we've, in theory, discussed that we can target this area, we can use fMRI imaging, we can lead to this clinical response, and they link the two in this paper. So they use the HAM-D metric. There's like a 76% reduction in symptoms, etc. But I think this is the major point from the paper. In 2020, SAINT is announced to the world formally. In this paper, Ellie Cole is another person in the group who ran trials and became clinical lead at Magnus afterwards. This is open label. They look at 21 patients, and this is the main figure I pulled from the paper. MADRS is the metric that we're going to use to evaluate efficacy, both in this, the next paper, and our paper. MADRS is the Montgomery-Åsberg Depression Rating Scale. It's a 10-point questionnaire, 6 points each, that surveys a wide range of depressive symptoms, all the typical suspects, dysphoria, appetite, sleep, pessimism, suicidal ideation, etc. 20 is roughly the cutoff from mild into moderate. 35 is the cutoff from moderate into severe depression. You see here, their average MADRS pre-treatment is around 35, and very rapidly, so 0 to 1, this baseline is the 5 days of treatment, we drop into roughly a 5 MADRS. You'll see this dotted line above 11, which is used as remission cutoff criteria. So when we talk about remission from here on forward, we're discussing a MADRS less than 11. This is specifically chosen, I'm assuming, because the FDA uses this metric to clear things. So going below 11 is what we're looking at. So 19 of the 21 patients in this study meet remission criteria. It happens very quickly, very robustly, and they follow these patients out a month, and the majority of them hold. Towards the end of the conversation, we'll look at what it looks like past a month, but this is pretty big to start. So they follow this up with a randomized control trial in 2022, in which they have 14 active, 15 sham. If you guys want, I can discuss later the actual equipment used in SAINT. It's a little different than typical TMS because of what you're trying to do. You know, it's much, much more. But you can actually hook up a research coil which stimulates the treatment without providing it. So it's very easy to do randomized control trials with it. Unlike, say, ECT, in which people always know if they're getting ECT. So what do they see here? It's a similarly good response. It's not quite as strong, but in the active arm, they have roughly the 60% remission, and they have around a 70% response. So response is defined as over a 50% reduction in MADRS score. That's the metric we'll use later too. By a month out, these roughly both drop by like 5–10%, but they still hold pretty well. And after this trial, the FDA clears SAINT that year, actually, very quickly for treatment-resistant depression. So what does it look like for bipolar disorder? I actually forgot to. Across the board for all the treatment-resistant depression trials, they did various cognitive batteries, and none of them showed negative side effect. Across the board, headache is the most common side effect with SAINT. You know, headache seems to always be responsive to ibuprofen, Tylenol, etc. So no real quantifiable side effect from the patient end. So we ran a trial here looking at bipolar disorder, led by our very own Dr. Peter Zandi. He was the trial PI, and Dr. Irving Reddy, who's sitting up back, was our site PI, and then George Almeida on the very left, or very right, is UT Austin's site PI. So what we wanted to look at is how does SAINT do in bipolar 1 disorder? At the time that we're writing up this protocol, getting it approved, etc., SAINT has not been looked at in bipolar 1 disorder. So this was a transition from depression for a couple reasons. One is, it's important, I didn't say it prior, but TMS is actually not cleared for bipolar depression. That's something that you all should be aware about. So having SAINT trying it and potentially, you know, adding to the evidence base to clear it would be big. It would offer that modality to patients with bipolar disorder that currently doesn't exist. But two, the other big thing you think of whenever you think of neuromodulation, especially a lot of neuromodulation in bipolar disorder, is mania induction. You know, this is something that's very real, not super common, but very real in ECT, TMS, etc. So that safety aspect is a big question on our end. So what do we do here? We have 10 patients, 5 at each site. They had to be in a DSM-5, bipolar 1 depressed episode, MADRS over 20, although our average was roughly 30. They had to have failed antidepressant trials. Most of them failed more than 2, 3, etc. And the novel part of what we did opposed to the other protocols is we required patients to be on an anti-manic medication for 6 weeks. So that's all the typical things you would think of, whether it be lithium, Depakote therapeutic, plus minus neuroleptic. We would discuss as a group every time prior to accepting a patient. So in terms of our results, this is the big figure from our paper. The black line traces the average MADRS reduction score. So we start at a 30, and by end, we're about a 12. And I choose to stratify this graph, though, into blue and red, responders, non-responders, once again defined by this 50% of symptom reduction, because I think it tells a slightly different story and perhaps the more important story. You know, we do see this robust change, which is pretty similar to the randomized controlled trial active arm if you were to superimpose them. But what I really saw as I was giving to SAINT, you know, to these patients, seeing them every day for 5 days for 10, 11 hours, is that some people got better very quickly in a very significant, noticeable way, and some people just kind of smudged and moved a little bit, right? Maybe even in a placebo way. So when you follow these blue lines, what you see is a significant portion of them, but even by day 3 or 4, they drop. And some of them meet remission criteria by then. And patients would always tell me, you know, end of day 2, day 3, definitely day 4, that they were feeling much, much, much better. And then the majority of these patients, all of them actually hold by a month again. But then if you follow the red lines, what you see is, you see some improvement, maybe, once again, could just be placebo. And then once again, they mainly all go back up on follow-up, right? Whatever was going on clearly didn't hold, may not have had effect actually to start with. The only exception is I highlight this one point in the bottom right, there's a black arrow. This patient actually did steadily improve but they didn't meet remission criteria till a month out. So this person arguably did have response, but it just didn't fit the study active outcome, the set outcome we measured. Also, when you look back at the treatment-resistant depression trials, there are 2 or 3 patients who have a similar trajectory. Don't respond very quickly, respond sometime out. Other measures, we gave the YMRS, which is the Young Mania Rating Scale, a very common mania assessment, multiple times a day throughout treatment for the aforementioned concerns. No one went above a 3. The YMRS goes quite high. 10, 20 is kind of the cutoff we're concerned about. And then we also did a cognitive battery, the CANTAB, which also showed no negative side effect. In fact, one of the measures in terms of impulsivity and executive function kind of trended towards improvement, perhaps just related to cognitive change related to depression. So what are future considerations? When I was doing this and as I assemble this talk and I talk to people about it, there are 2 big things that I think about when discussing SAINT. One is, how does SAINT do past this 1-month window, right? Like 1 month is what you see in all of these papers. It's what we did. It's a very reasonable amount of time to follow in any kind of study. But what does it look like 6 months? Brandon and their group followed their original cohort of 27 patients out for a year. And they basically just gave them mattresses. I think it was every 2 weeks, something like that. And they tried to detect when people's mattresses went above 20, which was their initial cutoff for the initial trial. And the average time for them was 26.5 weeks, so almost exactly 6 months a year. Although I will say the standard deviation is quite high. So you have some people, have relapses, depressive relapses in a couple months. Some people hold almost like the full year. So you see a wide gambit. So that's the one point, to give you a sense of the longitudinal nature. But the other point of this study, and perhaps the more significant point, is that what they did for all these patients is that they retreated them. They used the same target, they didn't re-fMRI, and they gave them the exact same treatment course. They actually did 5 days, they didn't do the 2 to 3. But they did 5 days, and they superimposed the MADRS decline, and it's roughly similar. It's very good, actually, really showing that SAINT as a treatment may be reproducible. It may be something we can use in a maintenance sense. It seems to have therapeutic intervention. The target seems stable enough that we can just reuse it over time. So I think that was the other big takeaway, that you have a treatment that you can just send people out to, if it becomes more accessible again. The other thing people discuss is what parameters matter. I discussed how ATBS in the beginning, accelerated theta burst stimulation, is just a catch-all umbrella for just any couple ways or many ways you kind of mix these permutations up. And there are things that, strike my mind as the provider. Could we not do 10 treatment sessions? Because 10 does not align well with a 9-hour workday. And could we do 8 instead, right? Maybe not, maybe not. Do we have to do 5 days? Do we have to do as many pulses? Do we need to target with fMRIs? Could we do other things? There are just a lot of ways to very practically take what seems to be a very successful protocol thus far and refine it, and I think when I look at the literature especially since 2018, 2020, when SAINT was announced, till now, there are a lot of people trying a lot of different things, and that's something we can discuss too. So some final thoughts before we move on to questions. SAINT seems to work very robustly in depression, specifically treatment-resistant depression, and it's safe in the depressive trials, and from our preliminary evidence in bipolar disorder, it's safe, although we did require patients to be on anti-manic drugs, which I assume will be a requirement for future trials and seems very sensible. Also, further research is just needed, right, to establish actual efficacy if we're going to look into bipolar I disorder as a whole. There is another study in bipolar II disorder. If anyone has questions about that, I can talk about that in the questions later. And then here's my thanks. Lots of people went into doing this, both at Hopkins and UT Austin side. Lots of people at Magnus and Stanford flew out here several times to train me, to troubleshoot me, to work on the MRI team, etc. It was a big team effort. We got funded through the Wazuski Brain Research Fund and the Milken Institute. Thank you, guys. Any questions?
Thank you, Dr. Lay. Great presentation and great work. Really exciting to see the project here lead to such success. This is certainly a really promising new treatment. I guess my one big practical question is, right this minute, does insurance cover it?
Yeah, that's a really good question. So I think the big conversation with Brandon and their team has been their conversation with Medicaid, Medicare that they've been doing. You know, once that falls, hopefully everything else falls. They told me yesterday that Medicare has cleared this now, and they're in discussions with Medicaid. If otherwise, though, it is out of pocket, and it's expensive. It's multiple thousands, as you'd imagine, covering the MRI, covering everything else, but the treatment can be pricey until the insurance covers.
Okay. Well, and follow-up practical question, who's providing it in Baltimore or Maryland right now, do you know?
Yeah, so right now, clinically, we don't have any providers. I should have maybe included this to start, but here's a map of all the clinical sites that are currently available. There's another one that just popped up in Florida that I didn't put a little ping for outside of Miami, but Acacia in the top left is one we just heard about. So you would have to send your patients to some of these. I think there's also one up in Mass Gen. I think a couple of their residents made a program too, but no one here in Baltimore right now.
Okay, well that's helpful to know. That's helpful to know.
Yeah.
Questions? Dr. Swartz.
Yeah, I think that's a really important question, especially since I kind of hinted at it. The fMRI process is a little rigorous. It's not like just sending your patient down to MRI and just getting a result back. You have to coach them through it, like specifically what they have to do. You have to work with the techs so they understand how to do it, so it's not a simple series. BrainSway released a paper a year or so ago where they don't run SAINT, but they essentially looked at various very accelerated protocols. You know, like I mentioned, anytime we just have many lots, we can call it accelerated, and they have decently good results, like pretty good. So I think that is the question to try, if we can just do this without fMRI targeting. I can't say for certain, but I think there's a chance that we can have some good result without it. I don't know if it's going to match what we see here, you know, if it's a little of one, a little of the other.
Right, of course, the throughput would be vastly higher and cost lower. Somebody, Dr. Margolis.
Yes, I'm very interested in your observation that there are basically two strata of patients, ones who respond and ones who don't respond, which reminds me of what we know what people like. Are there any clues, knowing that there's only a small number of people treated, any clues that what might predict response?
Yeah, so when I discuss this with them, I think one of the things they're looking into is trying to like qualitatively cluster symptoms based on response. They haven't done it from an imaging side, as far as I know, in terms of, hey, this cluster responds better than others. But that was the big question as we're leaving out. As of now, I don't think we know.
But you might imagine age number of past efforts, possibility of really
Right.
I will also admit, so part of why doing this was also novel, so to speak, besides the bipolar 1 aspect, is this is the first time SAINT had been run anywhere outside of Stanford. And like I've kind of hinted at, there are many technical aspects of it. And our first 2-3 patients responded really well when they were here to coach me. And it so happened our first non-responder is when I was alone doing it by myself. And basically the whole time I just thought, am I just not doing this correctly? Like, truth be told, I just thought, okay, like, am I not delivering this well? Here, there's a slide to show. This is actually what you look at as the provider. You don't look at the patient. You have 4 images, coronal, axial, sagittal cut of the brain, that you have to use this device to map in real. It's kind of like a video game almost, and you have to land it so your target in the bottom right aligns perfectly, and then the whole time it's pulsing rapidly, so it's just shifting constantly. So there's this very like technical aspect to delivery. So for that reason, I could have just done it wrong, like truth be told. We did have responders afterwards too, so I didn't just do it wrong the whole trial. But yeah, that was a thought too, that there's just this feasibility aspect outside of Stanford where their techs do it all day. They're really well trained. Like everyone I worked with out there was really, really good.
But interesting, Russell's question really speaks to the kind of precision medicine question of finding predictors. Yeah.
Yeah, I asked them that too, actually, about why they did resting. It seems like the proprietary algorithm they have is based on resting, so I don't know if they want to go towards task, but that's what they've been doing since the creation.
Huh.
Yeah, I think that like personalization aspect would be very useful, and it definitely gets at what Russ is saying too. Like maybe that addition would allow for better targets beyond just the resting, yeah.
Yeah.
Can you ask that again? Are you... Yeah. So for depression, TMS has been cleared since the 90s, et cetera, ITBS in the late 2010s, but not for bipolar disorder.
Dr. Lipsy.
Yeah, so in terms of the actual symptomatology, psychosis is the only one they report on, and there isn't psychosis in terms of the trials, although we didn't necessarily purposely exclude based on it in our study. The only measurements they have is really between the MADRS and the number of antidepressant trials, which isn't the best proxy, but you have these like severe MADRS scores, so presumably people are scoring in the 4, 5, 6s of the measurements you're discussing on MADRS. And like I mentioned, it's many antidepressant trials. Like some of the patients were upwards of 7, 8, et cetera. So the duration too is also what mattered, both in our trial and otherwise. A lot of these patients have been ill for months to years, more on the years end too. So we've definitely seen these very, very prolonged depressions.
Okay, so related to that, there's no correlation between how high the MADRS is and how likely you are to respond.
No. It just seemed like everyone just responds. At least when they do their initial trials, that's what they saw.
Okay. Other folks? Go ahead.
So, especially in the context of bipolar, but also more broadly, I was wondering whether there are considerations about like maintenance medications or effects on seizure control so far as efficacy.
Yeah, that's a really good question, both on the maintenance side after, but you mean going in, like what medications are? Yeah, so that's something I asked them, and they haven't, like we specifically had people on Depakote and lamotrigine, et cetera. They didn't ask us to discontinue anything, but I think that'd be one of the notions too. I will say though, so in ECT, we get this nice strip which measures seizure response. We get an idea of the activity. In terms of this, we don't really get that feedback. There is this dose you have to slowly titrate to. Everyone has, similar to a medication dose, like a dose based on anatomical measurements, skull, brain thickness, et cetera. So the ability to titrate that is the one metric they use. Like, can you get up to the actual dose you need? But we don't really see it on the response end. Although in theory, they're calculating, given this dose, given your anatomy, what level of electrical activity is reaching this part of your brain, et cetera, et cetera.
I'll ask you, Kevin, about this notion that has occurred to me that, we admit a patient onto our inpatient unit, and they don't have much to do all day long. And the idea of delivering this sort of treatment, given how time-consuming it is, seems like kind of a nice fit. It's not hard to deliver every hour on the hour all day for 5 days for someone who's already in the inpatient setting. I guess what I'm wondering is there any particular rationale for having someone inpatient for this treatment? Because of course the big downside in thinking that way is that you're dramatically increasing costs by talking about people having to be inpatient.
Yeah, so I think as stands, almost all the research they've done is outpatient. They've looked at other indications too. But when I initially talked to them, it seemed like inpatient was like a major goal for the reasons you mentioned. I suspect at this time it's just the typical inpatient indications, safety, suicidality, et cetera, et cetera. So you don't have to be inpatient. But I do agree, that's actually the first thing I thought of when I learned about this. This would just be a really good way to spend the week inpatient, hopefully improve, get discharged, etc.
Right.
And I'll also mention in terms of practicality, although we paint it as this on the hour, every hour, 10 minutes, 50-minute break, you can actually run way more patients than that. Out at Stanford and at many of these clinics, the machines, in terms of how hot they get, can actually run 3 patients every hour. So you kind of just do them 10 minutes, 10-minute break, 10 minutes, and people just line up and go in and out. So I think were we to get something like this, we could actually deliver it to many patients, not just one at a time.
I guess, we often think of that doing ECT inpatient makes a lot of sense, but there's a fair amount of side effect management, which has some value, which makes inpatient a little more valuable. But I guess we don't have the issue. With the same protocol, it sounds like there's essentially no side effects of any consequence that you would really want to.
Yeah, people do get tired. People do get tired. I had a couple of patients bring pillows and blankets, and it sounds like in the formal clinics they have like waiting areas. But there's definitely no cognitive or delirious risk. Everyone drives home at the end of the day, etc.
Right. Dr. DePaula. Yeah. Good point. Yeah. Thanks, Dr. Ewing.
Yeah, so everyone was there the whole time. So my patients, everyone we treated were free to wander Hopkins as is, just please come back at this time, and I suspect that's what it'd be elsewhere too. And then as the provider, you have to show up roughly 30 minutes to an hour prior. I don't have the imaging, the pictures, but part of the practical side too is that in order to do this all, there are a lot of very small mirrors everywhere on all the devices. You tape one to the patient, there's this infrared camera. There's like a lot of setup that goes around. So you have to do all that setup prior, and you have to make sure that setup is undisturbed when the patient's going around sleeping, etc. But otherwise, patients are free to do whatever they want.
Your point about the number of treatments and how 8 treatments would be more convenient in some ways than 10 from a timing perspective reminds me that one of the reasons our psychedelic center decided to focus on psilocybin and not LSD is for exactly the same reason, that the high in psilocybin lasts roughly 6 or 7 hours, whereas the high from LSD lasts something like 10 hours. I think it's that the amount of time just makes it easier to manage.
Yeah, and when I talked to Brandon Nolan about it initially, because all of the parameters have this like evidence base behind them, right? We didn't just make up these random numbers. The 5-day mark, though, I wasn't sure, and they said that was a practical decision. That was a Monday through Friday, right? We're just giving a lot. So we've already made some degree of practical consideration into it.
Interesting. Well, thank you. That was fascinating. Keep up the good work.
Thank you all.